Any questions from last time? I feel low-grade miserable right now, so we'll see how much we can get through. It's okay. At least you're starting 30 minutes early, so that's beneficial. Okay. What'd you say? Just go right now. I thought about it, and I was like, nah, I can't deprive them of such learning opportunities. It's what it is. I did spend some time yesterday reading up on. I was kind of sitting around not doing much, and I was reading up on like space travel, and it's like sci-fi kind of stuff. I kind of like it. I read this one book about anti-gravity. I couldn't even put it down. It was. I did find one good joke about time travel, but you guys didn't like it, so. Okay. Anywho. All right. So getting back, we were finishing up our discussion on MS. So remember that we talked about the DMT therapy, or disease-modifying therapy, that kind of slows down progression, helps to control symptoms, but it takes a long time. A lot of side effects, such as like immunosuppression, we talked about. Getting into just symptomatic management, here's some things like just specific issues you can run into. So for instance, with spasticity, we can use things like muscle relaxants, which we'll talk a little bit more about in the pain management section coming up in a little bit. But this is where things like baclofen and cyclobenzaprine can be really helpful, right? They basically help to kind of decrease the number of action potentials getting down to the muscle to actually cause those contractions. That's one way to do it. We see gabapentin and pregabalin coming back again, right? We talked about that a little bit earlier in this section here. Again, helping to enhance GABA effects a little bit, helping to kind of decrease those contractions. And then, botulinum toxin, as I mentioned, is another good option there as well. If those other two, kind of classes are not working, that's where you can just paralyze the muscle entirely, and that's certainly one good way to stop those contractions there. You can have similar kind of spasticity issues in the bladder as well. And so you can see here, we'll get to this in the urology section later on, but here we're going to use actually a lot of anticholinergic. So the bladder, being a muscle just like kind of anything else, will have its own sort of things to stimulate it. And we talked about, what's a big neurotransmitter that stimulates the bladder to contract? Acetylcholine, right? Remember, with the parasympathetic nervous system, what's the U in dumbbells? Urination, right? So here, how would you stop contractions of the bladder? It's an anticholinergic, right? So this is where we can use things like oxybutynin, sulfonylurea. Again, we'll talk about those later on in the class here, but that's one way we can stop the spasming of the bladder is by using an anticholinergic, right? Blocking those muscarinic receptors. And in some cases, medicine might not work. You have to go to self-catheterization. Any risk associated with that? Infection is a big one, yeah, so that's kind of a big issue there. You try to hold off on getting to that point if you can. For a lot of their sensory symptoms, a lot of it is neuropathic in nature due to the pathophysiology of the disease state, and so this is where some of our antiepileptics can be useful to kind of help stabilize the neurons a little bit to help decrease some of those sensations. So things like carbamazepine, phenytoin, and then the TCAs, anyone know what that stands for? Okay, tricyclic antidepressants we'll talk about in the behavioral health section. That's another group you're going to see used a lot for neuropathic pain issues specifically. And then in terms of fatigue, we'll actually get to this, talking more about these in behavioral health section. We'll talk about this a little bit in the surgery section actually with some of our sleep meds. But things like amantadine, we talked about being used earlier. It's kind of like something to kind of wake the person up a little bit. That can be useful there. Modafinil and armodafinil, those are actually Provigil and Nuvigil. Those actually get a lot of use for things like narcolepsy or patients with like shift work disorder. Anyone know what that is? What is that? We work a lot of overnights, and so you're up all night, but then you're supposed to sleep during the daytime. Does your brain really work that way? Not really, right? Because your pineal gland's releasing melatonin at the wrong times, and with the light being up, when you're supposed to be sleeping, it gets really kind of screwed up. So we have things like modafinil that can be useful for that. We'll talk about that a little bit later as well. And then, of course, all else fails, just take some speed, and that'll wake you right up, right? Well, we have legal versions of it, things like Adderall, Ritalin, and we'll talk about that in the behavioral section later on. Okay, so any questions? Kind of finishing up that section. If not, let's continue on, and we're going to talk about headaches. So something I've probably caused a lot of in your short time here in school already, but we'll get to how we're actually going to be able to treat those, right? So we'll talk about migraines first. Those kind of have the most medications associated with them. Certainly, have you talked about migraines at all yet? Okay, so we'll kind of cover that. Certainly there's different subtypes, right? So you can have things like migraines with aura, without aura. What's an aura? So yeah, so they kind of get these prodromal sort of symptoms there, where they kind of, maybe they start getting like halos around lights, or they get really light sensitive and things like that. They kind of feel when a migraine's coming on. That's kind of what you can see with an aura. Certainly, you can even have things like medication overuse headache, where patients are kind of chronically trying to manage their own pain, and then they end up causing kind of these rebound headaches that can occur. We'll talk about that. Tension and cluster headaches, we'll cover at the end as well. So getting into migraine, why do we get migraines? Anyone know? Yeah, a lot of it has to do with dilation of cerebral blood vessels, and basically what that ends up doing is puts a lot of pressure on things like the trigeminal nerve, and so that causes kind of spreading wave of depolarization that leads to that really severe migraine. So how do you think we might actually treat this? Yeah, we actually want to cause vasoconstriction. So we're going to use things that actually cause vasoconstriction of the cerebral vessels, and will relieve that pressure, and that should help relieve the migraine, right? And you'll see there's kind of different ways we can manage this. There's both what we'll call abortive therapy, which means once they actually have a migraine, how do you stop it from, stop those acute symptoms? And then there's also going to be preventative means to prevent the migraines from occurring in the first place. What's interesting, though, is that a lot of those preventative medications, they actually help to prevent some of that vasospasm that occurs there, some of that dilation of the vessels, but they can actually also cause a lot of migraines in and of themselves if used inappropriately. But we'll look at that later. But we're going to look at things to try to constrict down those vessels. Just knowing what those drugs are going to do, what do you think might be some potential side effects? Increased blood pressure is actually a big one, right? So you have to be careful with patients with like uncontrolled hypertension, because a lot of these will increase your blood pressure. With some other issues as well. So we'll look at some of the goals here. Mainly, a lot of it is going to try to improve their quality of life in a lot of cases. I don't know if anyone here suffers from migraines, but it can be quite debilitating. I remember I had an RA when I was in undergrad, who, when they had a migraine, basically their room was like closed off, had blackout curtains up, no sound, no light, don't even knock on their door. They're just out of commission for a couple of days, right? So it can be pretty severe in a lot of cases there. But our goals are going to be to try to make sure we kind of introduce medications that, one, if they have kind of chronic recurrent migraines, and we can try to manage that with sort of preventative medications, and then how to optimally sort of treat those acute sort of attacks. So certainly there's non-pharmacologic therapy we'll look at briefly. Do you think a lot of over-the-counter therapy is going to be sufficient for some of these migraines? No, it's kind of like using like a pea shooter for trying to kill an elephant or something, right? So it's just not really going to be all that effective. We'll look at some options there, and then prescription therapy is going to be sort of our kind of bread and butter. So certainly some non-pharmacologic things we can do are going to be things like stress management, relaxation techniques, etc. The best way to relax someone is just to say, just relax, right? Always works. Just kidding, it doesn't work. If they can avoid certain triggers, sometimes food or caffeine or alcohol, different things like that can actually stimulate these migraines to occur. So if they can kind of take a diary and see kind of what they were doing around the times when they happen, that can be useful to help kind of learn how to avoid their triggers. Sometimes you can't, like sometimes you just have to go to Pharm class and you just know it's going to happen, right? Anyway, regular exercise, getting enough sleep, all those things can help to prevent those as well. Okay. Some common food triggers frequently. Now, caffeine, if you had to guess, do you think it raises or lowers blood pressure? Typically raises it, right? So typically caffeine is vasoconstrictive. So what happens when people are withdrawing from caffeine acutely? You get rebound vasodilation. So a lot of people, when they're especially chronically using caffeine and they're coming off of it, they get a lot of rebound headaches because of that vessels that are dilating, putting pressure on those nerves, right? So that's a big reason why I have a lot of people who just like have to have their morning coffee, otherwise they just feel miserable. Some of it is related to that withdrawal effect, right? Even things like aspartame. What's aspartame? It's artificial sweetener, right? So sometimes that would trigger people. Tyramine-containing foods. Anyone remember what those are? The bougie foods, right? So your aged cheeses and meats and red wine, all that good stuff. Strong smells. I know that when my wife was pregnant, certain smells would just like trip her over the edge into having a migraine, which is unfortunate. So luckily, though, some women actually get migraines from just the smell of their husband when they become pregnant. I was a lucky one to not have that happen to me. So again, pregnancy is weird. We'll talk about that later. But all right, so anyway, so as I mentioned, our treatment can either be acute or preventative. We'll look at both of these. And again, it should be based off their presenting signs and symptoms. Because it's not just the pain that they're having, what also these patients usually presenting with? a lot of nausea and vomiting, right? So you're going to be looking at therapies to kind of help out with that. And frequently you're going to find, especially, we have a lot of these patients who will show up in the ER. We will be giving them multiple medications for pain, also for nausea, vomiting, and frequently a lot of fluids that kind of taking them back up as well. So we'll look at those. So generally, you want to administer medications at the onset of the headache. So especially if they have sort of recurrent migraines, you can have them have a prescription so that we have something available to them when they need it, sort of on an as-needed basis. And you're going to find that patients that have those prodromal symptoms, those auras, the medication is not going to do anything for that. But what's kind of the benefit if they do have an aura? They know it's coming, so they can take the medications before the migraine even starts, which is going to be much more effective than trying to play catch up and treating that pain when it's already there, right? Typically, try to use it no more than 2 days per week, because if you kind of use it more than that, you're going to see there's some issues with certain classes of meds we'll talk about, and then also they can lead to those medication overuse headaches we'll talk about later. So for mild to moderate migraines, typically the best things to start out with to try are going to be your OTC medications. Now, if a patient is presenting to you, say in the ER, in the clinic, for a migraine, a good question to ask them is what? What have you already tried? Because frequently they've already tried a lot of over-the-counter medications, but you can find out, like, well, how much of this stuff what you're taking? If they're saying, oh, every time I get a migraine, I only take 200 milligrams of ibuprofen. Is that enough necessary to treat a migraine? Maybe not, right? Depending on the size of the patient, you may need 400, 600, 800 milligrams, depending on the case there. But we can use our NSAIDs and simple analgesics. Typically, this includes, like, your NSAIDs are going to be good go-to medications here. Aspirin, I'd probably shy away from just because has kind of the worst side effect profile out of the bunch. But ibuprofen, naproxen, all those are fine. Now, anyone know what is found in Excedrin kind of products? There's caffeine. What else? Aspirin and usually acetaminophen, right? So it's usually like a triple drug combination. Now, again, when I say Excedrin, there's like a million different products that all carry the Excedrin name. So when your patient comes in, they say, oh, I take Motrin or I take Excedrin, like, it's important to kind of drill down to see specifically what they're taking, because it could comprise a variety of things, right? And again, my patient came in and said, oh, I already took Motrin. Do I want to start give them more ibuprofen? Probably not, depending on the dose they got, right? So you want to figure that out. But yeah, so caffeine, and again, caffeine is going to be good because it'll constrict those vessels. NSAIDs are going to be good for what? Helping with the inflammation that's occurring based on that pressure that's on the nerve there. And then acetaminophen is, again, working centrally to help with the actual analgesic effects. Does acetaminophen have any anti-inflammatory effects? Remember, that does not, right? So it's not good for the inflammation itself. Frequently, though, if patients are coming in, if they're so severe, they're coming into like the ER, or the urgent care, frequently we're going to be switching over, and especially if they're nauseous and oral medications might not be appropriate, we'll switch over and use parenteral medications. And so we'll talk more about NSAIDs kind of holistically for use for pain later on. But here we'll mention ketorolac or ketorolac, whatever you want to call it. Toradol is the brand name for that one. That's really like your go-to bread and butter IV NSAID. Right? You can use an IM if they don't have access, but parenteral administration, this is like your go-to NSAID. There are IV forms of ibuprofen, but it's not as common. Just stick with the Toradol and you're going to be good 9 times out of 10. Okay. Generally, we don't treat these with opioids. Okay. It'd be nice if we could use opioids for every problem, but there's enough side effects, there's enough other issues with them. We like to avoid these whenever possible, right? In terms of treatment for the nausea and vomiting, we're going to talk much more about these in the GI section coming up, so just kind of keep this in the back of your mind, though. One group we're going to use are going to be our phenothiazines, and so this is going to include things like promethazine, which is Phenergan. It's another brand name for that one, metoclopramide, and then prochlorperazine. So a lot of compazine being used for these patients here. Some of the benefits they have is, one, they're anticholinergic, which has some central effects on stopping nausea, vomiting. They also block dopamine receptors, and we'll look at how that's going to be really useful for treating nausea, vomiting a little bit later in the GI section as well. A lot of these, because they're anticholinergic properties, what do you think it does to kind of your mental status? They're very sedating, right? So, and again, that might be okay because if the patient has a migraine, maybe they just want to go to sleep, right? That's totally appropriate in some cases there. And so that can be a big benefit. Very, very good antiemetics, but very sedating. So you don't want them going driving off after getting a dose of Phenergan. Phenergan's nice as well. Certainly there are IV formulations, but it also comes as a suppository, which is beneficial. Why? So if they're vomiting, then you can use a suppository, right? Patients may not like it, but it's one option there if IV is not going to be a viable option. We'll look at 5-HT3 receptor antagonists as well in the GI section, but 5-HT stands for what? Serotonin, very good. Those are going to be like your Zofrans, right? Ondansetron, Zofran, that's going to be like your go-to serotonin antagonists. We give that stuff out like water in the ER. Again, very good antiemetic drug, but very, very commonly used. So, and again, like you'll figure it out, especially when you get into Pharm in the advanced didactic summer semester there. But there's certain drugs like you're just going to kind of know the doses of, and like you're going to use them quite commonly. Things like Toradol, things like Zofran, things like Tylenol, Motrin. Those are kind of the bread and butter stuff you want to know. Morphine, another good one. Just have kind of general ideas of the dosing you're going to be using for those patients, because you're going to see it all the time on rotations. Anyway, so we'll talk much more about that in the GI section coming up. So for more moderate to severe migraines, maybe once they've already gotten an NSAID, once they've gotten some antiemetic action, this is where we're going to be jumping into using our more abortive therapy. This is where we're going to get into our ergots. Remember we talked about ergots earlier as being dopamine agonist, right? We're going to use them from a little bit different option here. We're actually going to use them for their serotonergic effect, okay? So we have a couple in this category here. We have ergotamine tartrate, and then we have dihydroergotamine, or DHE. If you ever hear DHE, that's what that stands for. If you hear ergotamine, you think ergot, you think that fungus, you think vasoconstriction, and it does that by activating these 5-HT1D and 1B receptors. Now, you know there's different subtypes of receptors for different neurotransmitters. Serotonin probably has the most variety out of the whole bunch. They all do something very different, right? So the 1D, 1B agonist is going to cause constriction of those cerebral vessels and relieve that pressure on that nerve there, okay? So basically, the other nice benefits of using the ergots, which come in a variety of dosage forms. We have some IV forms, we have intranasal forms, which could be good, especially if they're having nausea, vomiting. They have long half-lives, which is great as well. And why is that? Because you don't want them to have a recurrent migraine, right? So these are medications, typically, the ergots you would not be typically not prescribing for outpatient use. I've really only seen it used on the inpatient side for the most part, or in the ER setting. But typically what you're going to find is that you want them, it's nice to have a long half-life because it prevents that recurrent migraine from occurring. So your patient comes in for a migraine, you treat them, but hours later, once the medications wear off, they have a risk for developing another migraine. So this is the nice thing here, is it prevents that recurrence in those cases. But the side effects are pretty bad, right? So I've found a lot of providers are shying away. You might see some older providers kind of going with the ergots kind of first line for these migraine patients, but I'm seeing it less and less commonly. But again, that's very much depending on where you work at. The reason why that is because it is a very powerful vasoconstrictor that we can see a lot of other issues that show up with it. So one's nausea and vomiting. These are typically going to cause a lot of nausea. What are these patients already experiencing? Nausea, vomiting, right? So you have to give this with some sort of antiemetic drug, because otherwise, yes, they absolutely will be throwing up, right? You also see hypertension is going to be worsened. So if they're already coming in and they're already hypertensive to begin with, which, maybe a little hypertensive, just, or at least above their baseline because of the pain they're experiencing. But certainly if it's, they're sitting in the 180s systolic, like this may not be a good drug to use, because you're only going to increase that further, okay? And because of that, remember we talked about St. Anthony's fire. What was the symptoms those patients were developing? The burning sensation. Remember that limb ischemia that they're developing because of the vasoconstriction? Well, guess what? These ergots do the same thing, because it's essentially the same compound. So you can develop cold, numb, painful extremities because you're not delivering enough oxygen to those tissues there, and you actually get gangrenous extremities in some rare cases. Now, this is not like with a single dose. This would be for someone who's maybe giving themselves repeated doses, maybe someone got too much of the drug. Rare, but this can occur in some cases there, okay? You can see things like MI can be exacerbated by this. You can cause bowel ischemia and cause a stroke, so there's some pretty serious consequences that can come about from this. So because of that, here are the contraindications. These are good to know, because you might have a case on a test that comes up and it says, hey, patient comes in, this is what they've already tried, what do you want to use on them now? Okay, and so based on what they're presenting, like, you may decide what kind of medication you're going to use right there. So again, if they have hypertension, that's again, it's a relative contraindication, but if it's acutely uncontrolled there in the setting you want to administer it, don't want to give it, right? If they already have vascular issues, coronary issues, avoid this medication. And definitely if they are pregnant, what do you think would happen if you squeezed off all of those little blood vessels going to a fetus? Not great, right? So this is actually can cause a way to cause a chemical abortion potentially. So these are absolutely contraindicated. We'll talk about pregnancy categories later on. There's A, which is like super safe, B, C, D, and there's X, right? It's so bad they skip all the rest of the alphabet, go straight to X. This is a category X drug, right? No benefits whatsoever, no situation where the risk will be outweighed by the benefits, right? Okay, and then another thing is you don't want to use these within 24 hours of the triptans. The triptans are the next set of drugs, which are going to be kind of our gold standard we'll talk about next. You don't want to use them within 24 hours because the triptans will also be vasoconstrictive. Guess what happens? You put an ergot on top of a triptan? Yeah, risk for stroke, risk for limb ischemia, all those things are not great, right? So you got to watch out for the time frame. Ask them what have they already used, because again, patients with recurrent migraines, they've probably already used one of these on the outpatient setting, so you got to find that out. Okay, so getting into those triptans, the reason why I call them the triptans because they all end with triptan, right? So Imitrex or sumatriptan was kind of like the first one that came out. It was really kind of revolutionized therapy for migraines when it first came about, because again, safer in terms of a side effect profile than the ergots were for sure, but they work almost identically, right? Basically causing the agonist effect at the 1B and 1D serotonin receptors, okay? Other nice thing here as well that Imitrex when it came out, it had subcutaneous formulations, so you can inject it if you needed to. If you didn't have IV access, you had nasal formulations you could use. So again, very good if the oral route was not going to be good for them. Which route do you think would have the fastest onset? Say if you're going like oral, parenteral, or intranasal. Is the fastest. Parenteral is probably going to be a little bit faster, right? So you have to still think about where the drug's going. With the intranasal formulations, you still have to go around the venous side of things before it's going to get to the heart and eventually to the brain. If you're giving it to a peripheral line or, say, intramuscularly, it does work a little bit faster, right? It doesn't have to get absorbed through the nasal mucosa and all of that. So, but the slowest obviously would be what? Oral, right? So oral's going to have the slowest onset. That's maybe better if they have auras with their migraines, and that way they can kind of head it off before it even starts. It may be great, but a lot of times intranasal is going to be the fastest one that they can administer themselves. It could be a good option there. Anyway, so all the other triptans, really the biggest differences between them tend to be either what dosage forms they come in, what their half-lives are, what maybe the insurance is going to cover, different things like that. So we'll kind of go through them, kind of look at some of their idiosyncrasies one by one. But again, you have sumatriptan, you have zolmitriptan, rizatriptan, neurotriptan, almatriptan, frovatriptan, and then elatriptan. Right. So again, why do you think we see so many in the same class of drugs? Money, exactly. The drug companies were like, man, that Imitrex is really getting a lot of money from all these patients with migraines. We got to come out with our own variety, right? Just like we have a gazillion different ACE inhibitors. Same thing here, right? A lot of people have migraines. And again, working the same similar mechanism as you will see with the ergots, which is activating those 1D and 1B serotonin receptors. It's going to be causing vasoconstriction of the cerebral vessels. It's going to be decreasing inflammation. All that's really good. For most patients, they will find the first dose is going to be effective there, but again, depending on the half-life of the drug, recurrence is going to be a factor, right? So, for instance, with like say sumatriptan, around 40% of patients are going to have recurrence during the same day because the half-life just isn't as long as something like an ergot might be. However, you're going to see that percentage is going to be decreased with things like frovatriptan and emerge are going to be the two that have like kind of the longest half-lives, and so those have a decreased risk of recurrence. Anyway, so side effects you're going to find, and this is pretty frequent for these patients there, so it's not the, in terms of safety, it's fairly safe, but they're struggling to develop some of these side effects here. So again, they can experience things like chest pressure, chest pain. Again, you want to monitor their blood pressure, look for things like that. Just because they experience chest pain doesn't mean you have to do a full cardiac workup, but certainly know your audience, right? Know, okay, do they have a previous history of coronary disease? Is this going to be a great set of drugs for these patients or not? Other things they can develop, some nausea, some somnolence, dizziness, not nearly as severe as you will see with the ergots. But again, just depending on what the patients received before, what they kind of tolerate based on their history. Again, in terms of contraindications, if they have coronary artery disease, history of MI, angina, cerebrovascular disease, these are all things that are going to make them more at risk for causing that vasoconstriction, causing some issues there. So be careful with that. And again, do not want to use these within 24 hours of ergots, right? MAO inhibitors, right? So we talked about those as being kind of those old school antidepressants. We talked about a few for Parkinson's disease. You would not want to use these together as well because, again, they can cause too much serotonin activity, can cause some issues there as well. So how do you choose a triptan? Typically, sumatriptan's the oldest, so it's off-brand. It is fairly cheap for the most part as a comparison to some of the other newer ones. And again, most patients are going to respond fairly well to it. You see here with the sub-Q injection, most patients, 3/4 or so, will get relief within 15 minutes or so. So it's not immediate, but it's still fairly quick for the most part. You see here with just like say the PO forms, may take up to 2 hours. So again, it's a long time for those patients to be experiencing pain before they get some relief there. As I mentioned, the second generation ones were really designed, kind of everything that came after sumatriptan was designed to decrease those recurrent headaches, maybe to increase bioavailability so that we actually get more drug coming into the system there, and to decrease some of those chest symptoms that we talked about. It's kind of their designs. And so they tend to have a little bit better potency at the receptor, so a little bit more specific for acting at those 1D and 1B receptors. And they have other things like increased lipophilicity. So what is that going to do for their actions? Across that blood-brain barrier much more easily, the more lipophilic they are. Good. And they have better bioavailability, longer half-lives, right? So again, all favorable pharmacokinetic profiles. So zolmitriptan is one here. You'll find this has pretty similar efficacy to sumatriptan. Again, ODT is a possible formulation you can use here. What does that stand for? Remember? Oral disintegrating tablet. I think we mentioned one of those perhaps the last time we talked, but again, the benefit of an oral disintegrating tablet is you don't have to swallow it, right? So if they're nauseous, you can just kind of put it in their cheek, and then that will dissolve and absorb buccally, right, from the cheek, so that way you don't have to worry about swallowing anything. Can be beneficial. Neurotriptan, or Emerge, as I mentioned, has one of the longer half-lives, so about 6 hours or so, and good bioavailability, so that way it's going to be able to stick around for longer, act for longer, and that way you see decreased recurrence with those patients there. However, one of the problems, though, is it has a little bit slower onset, maybe up to 4 hours before they really get the relief with that. So again, kind of a trade-off between, okay, do I want really fast relief, or do I want something that's going to prevent that recurrence from occurring, and maybe patient-to-patient sort of cases there. Then you have rizatriptan, another one comes with the ODT. This one actually has a drug interaction if you give it with propranolol. Remember what we use propranolol for? For blood pressure, for... Nope. What else do we talk about propranolol for? Anxiety, potentially, right? So like performance anxiety specifically. What else? Is it perhaps an antiarrhythmic? Maybe like a class, remember? 2 antiarrhythmics. Remember our beta blockers are class 2 antiarrhythmics? All this stuff comes back, guys. You can't drop all that old information. Still relevant. Anyway, but you can actually also use propranolol as a preventative agent for migraines. You can actually help. And why do you think we'd use a beta blocker to prevent a migraine from occurring? Essentially, yeah. So it kind of regulates the vessels a little bit. And again, propranolol, if you recall, causes a lot of nightmares in elderly patients. Remember, because it's very lipophilic, right? So this is a good one to use for CNS stuff. So use propranolol, and it basically, if you recall, beta 2 effects on blood vessels does what? If I gave norepinephrine and I activated a beta 2 receptor on a blood vessel, that would cause what? Does it? What do I do if I give beta 2 agonists in the lungs? Causes bronchodilation, a smooth muscle relaxation. What does that do in the blood vessels? Smooth muscle relaxation, so it also causes dilation of the vessel. So if I give a beta blocker, perhaps I can prevent that dilation of the vessel, which we mentioned was part of that pathophys of a migraine, right? See how it kind of all comes together? So maybe you don't, but you can watch the video again. But point being is that by giving that beta blocker, you kind of regulate things a little bit. So it's a common drug that patients will be on for preventative measures to prevent a migraine from occurring. If you combine this with something like rizatriptan, you can actually end up seeing a 70% increase in the AUC. It's that area under the curve, or overall drug exposure, which means you can end up having way too much rizatriptan in the system for too long. And what do you think that might actually cause? Like the chest symptoms, it's going to cause the hypertension, right? All the side effects we mentioned there. So you have to be really careful, and actually will decrease the initial and the total daily dose, so that way they will not have those kind of interactions there. So again, something you want to be looking for whenever you're adding a new drug onto their regimen, right? Rizatriptan tends to have kind of the fastest onset out of the oral triptans, so that's one of its claims to fame. And again, look at this if you notice how to change the dose if they're taking propranolol or not, right? And you'll actually find that if you look it up like in Lexicomp or something, it'll tell you specifically if they're on propranolol, you have to decrease the dose by half or so. Amitriptyline is good bioavailability. This one is metabolized by CYP3A4, so you have to be careful with that. Again, interactions could be affecting that. It's also metabolized by monoamine oxidase, so if they had any inhibitors on board, that could also increase the AUC, increase risk for side effects, etc. Alitryptin, another 3A4 substrates that could be affected by drug interactions. And then you have Provertryptin. This one, again, has the longest half-life. So of all of them, they would have the least amount of recurrence. You'd expect it to be basically Provertryptin, right? Which works pretty similar to Neurotryptin, was the other one that had a long bioavailability, or long half-life, and again, probably slower onset as you would expect. Okay. So for those acute treatments, essentially what you're going to do is you'll have a migraine-specific agent, so again, like an ergot, like a triptan, in patients who are having a severe migraine, especially if they've not really responded well to NSAIDs, either over-the-counter or prescription NSAIDs. And then if they're having either early or really significant nausea, vomiting, that's where you can end up using the non-oral routes, either nasal spray or sub-Q injection, IV, whatever the case may be. Okay, or for sub-Q, it's about an hour or so for it to really kick in, have its full effect. For intranasal or PO, expect about 2 hours or so. Remember, we said do not use triptans within 24 hours of an ergot or another triptan, because again, you can end up seeing excessive prolonged vasospasm, uncontrolled hypertension, chest symptoms, MI, stroke potentially in some rare cases. Be careful with that. And then, as I mentioned, try to avoid using more than twice a week, right? If they're getting migraines more than twice a week, that's when you need to really start looking into some of those preventative measures, and we'll look at those meds here in just a second. Okay, and here's a nice little flow chart kind of going through how you would kind of, once you have the diagnosis, how you would manage these patients. Again, patient education is a big one. Hey, avoid your triggers, take a diary so you can find out what those triggers are, etc. And then looking at the actual severity and the degree of the associated disability. So again, if it's really just kind of, I have not actually been in presentation mode this whole time. No one even told me. So unprofessional. Jeez. You can tell I'm ill because I didn't even notice that. But anyway, again, depending on how disabled they are just by the migraines themselves, you may just consider prophylactic therapy just right away, which I mentioned we'll look at in just a moment. Again, if they're having nausea, vomiting, obviously consider using an antiemetic drug. We'll talk a lot about those in the GI section coming up. And then for the more mild to moderate symptoms, again, start easy. Start with the kind of the most innocuous stuff. Things like your NSAIDs, ibuprofen, naproxen, aspirin, any of those are fine. And then sometimes we'll end up using those combination therapies, right? So acetaminophen, aspirin, caffeine, those are your Excedrins, right? Anyone know any other kind of common brand names for that combination of drugs? We should say Midol or things like that, things for menstrual headaches. Those are frequently that combination of drugs you're going to see there as well in a lot of cases. But and then if they're having really severe symptoms, if they're coming in and they say, oh, we have tried NSAIDs before, they don't work, just give me something for this headache, it is so bad, that's where you're going to go ahead and jump to most likely your triptans. If that was not available, or if maybe they had a contraindication of that, then they can use their ergotamines. I've had some patients that are like, yeah, the triptans just don't touch it. I always have to get DHE, and listen to your patient. They say, hey, they know what works for them. Go ahead and go with that. If they come in and say only Dilaudid works for my headaches, maybe take that with a grain of salt. But for non-controlled substances, listen to your patients, right? Anyway. Okay. Any questions on that specifically?
If they wanted to use a long half-life one and then they get a headache before that, is there anything they could use for that?
A lot of it's like just symptomatic management for the most part. Again, you don't want to dose stack them because then they can end up. Now, if it was something like, they're using the same triptan, I'd be more likely to use that closer together rather than using different ones, because again, depending on their potencies and things like that, the receptors, you're more likely you're less likely to have significant side effects from using the same drug together than you were if you were to kind of switch them up, or like using ergot plus a triptan or something like that. Yeah. Okay, so looking at medication overuse headaches, because a lot of people will self-treat for their own headaches, right? And so they may not even realize how significant of a problem it is, before someone realizes, hey, you actually should go get this checked out. Should be a big issue. I'll tell you, I was reading a website yesterday, and there was there's like a relationship part of the section where this wife was asking, is she in the wrong here because her husband takes this medication that he has to go to the bathroom quite frequently. They have twins that were just born, they're a couple months old, and every time that the diapers need to be changed or the babies need to be fed, all of a sudden he has to go to the bathroom. Convenient, right? And he'd be in there for like 25 minutes, 30 minutes, and she's like, this is getting ridiculous. I got twins here. I need some help. And so she started turning off the Wi-Fi whenever he would go into the bathroom. Because she's like, well, do you have to go to the doctor for this if it's so severe? And he's like, no, I don't have to go to the I don't have to go to the doctor. But then she started turning off the Wi-Fi when he went to the bathroom. All of a sudden, his visits started getting much shorter. So she miraculously cured his affliction by cutting off the Wi-Fi. Anyway, did a lot of reading yesterday, as it turns out. Anyway, so as I mentioned, patients will kind of self-treat before they get help in a lot of cases here. So this can occur if patients are overusing opioids, triptans, or gotamines. Remember, they may not even be getting these medications, these prescription ones, from themselves, their own prescriptions. They may get it from someone else, right? So consider family members in the home may be sources for some of these meds. Typically, if they're having headaches greater than or equal to 15 days per month, and they're using some of these medications, these abortive sort of medications, more than 10 days out of the month, or if they're using other analgesics like your over-the-counter NSAIDs and things like that, if it's more than 15 days per month, that's generally considered a medication overuse headache, where typically the meds aren't really helping that much more, and in fact, if they don't use the meds, then they get these kind of rebound headaches that can be even worse than what the headaches were originally, right? So how do you think you would manage that? Say, well, stop taking the medications, they're the ones causing your headaches. Taper is a big thing, right? So you want to wean them off of the medications there. If it's less than, say, 7 to 12 analgesic tabs or caps per day, this is kind of just a rule of thumb kind of thing. You can discontinue the analgesic. Some people will recommend doing a taper, maybe 4 to 6 weeks in some cases, depending on how severe it is. And we would actually begin prophylactic medications. We'll talk about those in just a minute here. Withdrawal symptoms, may last days to weeks. You gotta let them know, hey, like you kind of got yourself in this issue, and it's going to be a little bit till you kind of get back down to your baseline. That's why the tapering can be helpful. If the symptoms get really severe, bump them back up on the dosage, and then again restart that taper. You can always readjust those sorts of things there. If they're more than 12 caps per day, or if they're pregnant, because again, pregnancy-related headaches are quite frequent, don't abruptly discontinue. Build in one of those longer tapers, like 6 weeks or so, in order to get them off of that. So who's going to be a good candidate for preventative therapy? Well, certainly if they have recurring, more frequent migraines, especially if they're kind of interrupting their normally daily routines, or if they are going to have maybe a history of overuse of other medications. Maybe they have a contraindication to, or other meds have stopped working, things like that. This is all going to be patients who are going to be good candidates for preventative therapy. So first line are going to be your beta blockers. Typically this is propranolol because again it's very highly lipophilic, and so it's going to get into the CNS pretty easily there. And for a lot of patients it is about 80% effective, right? So pretty good odds it's going to work for your patients. However, who might not be a good candidate for propranolol? They have asthma, or they're elderly, like those are good patients who are not going to be great candidates for that. So you can use an alternative, right? There's nothing specific about propranolol other than its lipophilicity. Any of them could work. So atenolol, metoprolol, all those are totally fine. Keep in mind though, you want to start low dose and titrate up, because if you give them a full blast beta blocker, you can actually end up causing that vasodilation, actually can induce a headache. So that's kind of the thing with these, is that yeah, they're good for preventing migraines from occurring, but they initially by themselves can actually cause migraines. You got to be really slow and kind of gentle with it. Some other meds that patients have tried, so maybe they're not a good candidate for a cardiovascular med. Maybe they have a history of heart block, and a beta blocker would not be a good candidate. They would not be a good candidate for that. This is where our anticonvulsants come into play here. Most commonly, I either see something like valproic acid. It's going to be a good option here. Now, which patient population I mentioned would be a bad candidate for valproic acid? Yeah, if they're pregnant, you do not want to do that. Neural tube defects, not great. Again, they're thought not to really affect the vasodilation aspects of it, but more that kind of spreading wave of depression that occurs once those nerves are being activated by that vasodilation. And topiramate can be another one. It's kind of slowly becoming more first line for patients that aren't good candidates for beta blockers, so I see more and more patients using that. And again, we talked about side effect profiles for topiramate previously. Other things they can try, things like tricyclic antidepressants. Probably amitriptyline has the most evidence out of the bunch of those. We'll talk much more about these in the behavioral health section, as I mentioned later on. SSRIs. Now again, these are not going to be frequently used, but they may actually worsen the migraines in some cases there. But patients may need to be on it anyway if they have concomitant things like depression or anxiety, etc. And a lot of that has to do with their effects on actually blocking reuptake of serotonin. So if there's more serotonin in the synapse, they can work on those 1D and 1B receptors. That's kind of how they think that these are effective for preventing migraines potentially. And then calcium channel blockers are going to be another one we'll see being used. Verapamil is typically most common, but diltiazem could be used too. Keep in mind these are not going to be your dihydropyridines. If they use any of them, it may be nifedipine, but it's not super common. So typically your non-DHPs are going to be the ones to go with. If the patient was a bad candidate for a beta blocker, but they could still get something that's cardioactive, I'd probably go with a verapamil or something before jumping to the anti-epileptic agents there. And then why do you think Botox would be good? Like, where would you inject the Botox? Help prevent migraines? Like, into their brain? Like, that wouldn't work. Why the back of the head? A lot of those neck muscles that tend to pull back on the head can actually lead to those migraines there. And so I've seen some Botox being used in some of those neck muscles in order to kind of loosen them up a little bit, prevent those migraines in the first place. That can be one way you might see that. Again, very specific subset of patients that would be good candidates for that. Okay, as I mentioned, start low and go slow, because again, a lot of these, if you give them full blast doses, you can actually induce those migraines there, so be aware of that. And again, you may not be able to get down to 0 migraines, right? You need to have the conversation and say, well, we can reduce the number of episodes, may not be able to get rid of them entirely, right? And then, consider after, say, a couple of months, see how they're doing. If their, migraines are pretty much under control, you can try tapering off if you want to. It doesn't have to be a lifelong kind of thing. It just depends on the patient there, right? And so again, if they meet prophylactic, criteria to use some of this pharmacotherapy here, again, look at the different kind of options that we can use based on the type of patient, right? So if they occur in a pretty regular pattern, so say they're only menstrual related, so about the same time every single month that they're going to get these headaches, well, you can use medication just around that time. That's totally appropriate. Things like NSAIDs or triptans would be okay, right? If they have hypertension or angina, well, how do we treat angina? Beta blockers are a big one, right? So we can use beta blockers for that, right? They have hypertension, beta blockers are fine. Calcium channel blockers are good options, right? So that could be good for them. If that's ineffective or they're not a good candidate, then try using something like a tricyclic antidepressant, something like amitriptyline. Again, if that's not working, if they have like a seizure disorder, anticonvulsants are a really good option for those patients there. So a lot of it's like looking at their comorbid conditions and seeing where you can kind of pull some double duty, right? So they have a history of angina. Well, why give them one drug for angina, one for migraines? Like to give them one for both, right? So if you can try to double up the uses for the meds, it's always going to be more effective. Looking at migraines in women, typically are a little bit more prevalent in women. Consider things like, menstruation. Sometimes you can find that their hormones may be affected. Again, certain times of the month, you're going to find that their hormones may lead to developing these migraines, developing these headaches. Again, introducing oral contraceptives, which are just hormones, right? The estrogen and progestin can affect that as well. So some patients may actually find that starting an OCP will actually help their migraines. Some people will find that it makes it worse, right? So you'll find when we get to the OB-GYN section that finding the right type of birth control for your patient can be a lot of like kind of hit and miss. Like, okay, we'll try this one. That doesn't work. Just try this one until you kind of settle on the right one there, right? And certainly pregnancy, hormones are going to be raging there, which can induce headaches for those patients. Again, their sense of smell is also affected, which can lead them to have more things triggering their migraines, right? And then things like menopause can also affect that, because then what happens to your hormone levels in menopause? They plummet, right? So again, that could lead to those headaches and those migraines. So with menstrual migraines, again, because it is fairly predictable, again, about the same time every month, that's where you can end up taking those medications, the kind of acute treatment medications just around that time. That's totally appropriate. And NSAID, triptans 2 or 3 days beforehand, totally fine. Some patients will do better with taking estrogens around that time, but we'll talk about that later when we get to the OB-GYN section later on. And typically just take it for that 5 to 7 days, kind of cover them during that period, and then they'd be good to go. As I mentioned, oral contraceptive use will either promote, change, or relieve migraines. Most women that will experience no change whatsoever. So it really just depends on the person, how sensitive they are to it. Now, if they notice, what are your options? Say you start them, they want to be on birth control. They have good reason to be on birth control, but it's causing this increase in migraines. Well, what can you do about that? One, you can try changing the formulation, as I mentioned, maybe changing the dose or changing the type of progestin they're on entirely. You can try using just a progestin-only pill if you believe that estrogen is going to be kind of the component that's causing the migraines. That's one way to do it. You could discontinue the oral contraceptive, or you can actually decrease the number of estrogen withdrawals. Sometimes you'll find, if you look at like a pack of birth control, like typical birth control, you have kind of 3 weeks of therapy, and then what's that last line of meds? Sugar pills, right? Why do we give sugar pills? That's placebo. So that way you're always in the habit of taking a pill every single day, right? So it helps with compliance there. Some people will find that the migraines will get worse when they have that estrogen withdrawal, when they hit that placebo period. And so in some cases, you could just continually take the estrogen and never actually have the withdrawal period, right? And so there are certain formulations that are designed like that, like Seasonal or Seasonique, where they're designed you only have 4 periods in an entire year. And so you'd have 4 periods where you'd have those migraines potentially, right? And just take meds around that time. Point being, there's a lot of different ways you can get around that. We'll talk about those much later. I'll talk about my fascination with the fact that you can change the menstrual cycle to a great degree with medications. I thought it was black magic when I was learning about honeymooning and all kinds of stuff like that, but we'll get to that a little bit later on. And then just some vitamin B6 can be very helpful as well. Again, not going to hurt anyone to have a little bit extra B6 in their diet. In pregnancy, though, it gets a little bit more complicated. Typically, we like to use how many drugs in pregnant women? No drugs would be ideal, but if you can't get away with that, acetaminophen tends to be the safest out of the bunch, right? But again, as I mentioned, how often is the acetaminophen going to be effective for a really true blue migraine? Probably never, right? So you try to get away with what you can, but if you need to use an alternative, triptans are category C, and we'll talk about that later, but anyone know what category C really means? It's like, I don't know. We don't really know how good if it's going to cause any harm to the fetus. We don't really have any evidence to show one way or the other. It's kind of like, like the really safe drugs are A and B. The really dangerous drugs are D and X, and like everything else gets lumped into category C. So I would not feel super comfortable if my wife was pregnant to give her a triptan just based off that evidence, right? But again, maybe on a case-by-case basis, the risk may be outweighed by the benefits potentially. NSAIDs, you don't want to use in the 3rd trimester. There's some issues where decreasing prostaglandin synthesis in that 3rd trimester can cause some issues with things like certain vessels like the ductus arteriosus. And again, we'll cover this in more detail in the OB-GYN section later. Certainly never want to use an ergot because they're category X. So question is, maybe opioids are okay for very short-term limited use for those patients, maybe an option. So it just really depends on the case there. And again, for preventative, typically there's not really any good pharmacologic measures for them. Typically you want to avoid, again, chronic drug exposure if you can, so not a lot of good options there. In terms of tension headaches, again, mostly you're going to see a lot of OTC use for these patients here. Some patients will actually use what they call Fioricet or Fiorinol. Anyone ever heard of that drug before? See it a lot in patients coming into the ER, especially if like chronic pain issues. You always see that as like an add-on to their drug list there. Typically, this is a combination of caffeine and butalbital. Butalbital is actually a barbiturate. It fits into that category just the same as it would for phenobarb or pentobarb. But it's caffeine and butalbital. And then Fioricet, think acetaminophen. Fioricet has acetaminophen in it, and then Fiorinol has aspirin in it. Okay, so it's important to know the distinction there because, too much acetaminophen or too much aspirin can be a problem, especially if they're overusing these medications there, but they can be problems for very different reasons depending on the case there. Actually, I just had a recent case at the Poison Center where I actually had a patient who she had diverticulitis and having a lot of pain associated with that, and was self-treating herself with a ton of aspirin every single day. By the time she actually got into the ER for management, she was already having very severe aspirin toxicity that had been kind of developing over the course of many days and weeks. So again, you gotta be really careful with these OTC things because they can be dangerous used incorrectly. Another really important thing to consider too, a lot of urine drug screens will have barbiturates as one of the things they test for. I would tell you 9 times out of 10, I'll have patients will come in for like ultramental status, or they're just coming in for whatever reason, and they get a UDS, urine drug screen, and they show positive for a barbiturate. And every single time the doc or the provider is like, well, which one is she on? Which one is he on? What is the patient taking? Most of the time, it's going to be that butalbital. You find very rarely do adult patients actually taking a barbiturate like phenobarb or pentobarbital that wasn't administered like they're in the ER. So most of the time, it's Fioricet or Fiorinol is doing that. And again, a lot of people end up overusing this, causing rebound headache. So questionable efficacy, but you'll find a lot of people will use it anyway. Okay. In terms of prevention of tension headaches, things like amitriptyline tends to be a little bit more effective for this and some of the other therapies we talked about. SSRIs are going to have fewer side effects. These are things like your Prozac and fluoxetine, citalopram and things like that, but less effective than the TCAs, right? And then another thing is that a lot of headaches can be induced by smoking, so if you can get them to stop smoking, that can also help as well, right? But how often does smoking cessation work? Yeah, not as often as you would like, right? And then finally, we'll talk about cluster headaches real briefly. Again, these can be very, very severe headaches, probably even worse than migraines a lot of times. You'll find most patients will end up using something like an ergot or a triptan for these patients here. Typically, you want to go more parenteral or, like I say, intranasal if you have it available, just because you want that quicker onset. And I've actually found some cases where oxygen therapy can actually help them out and help to kind of stop the headache a little bit sooner. So you can give them 100% O2, and that tends to help out as well. For prophylaxis for cluster headaches, this is where verapamil is going to be effective in a lot of these patients here, so I'd recommend that for those patients. And actually, if they didn't respond well to that, they've sometimes used lithium. You know what we use lithium for? Bipolar disorder, right? And so they found some efficacy here, but there's a lot of monitoring associated with it, a lot of side effects, so that's definitely not one that I would jump to by any means unless it's really necessary. For some of those patients, they do respond well to corticosteroids, help decrease inflammation, but again, we don't like to use that for long term either, because of the obvious side effects we talked about ad nauseum, right? Okay, so that's it for the neuro section. Any questions? I'll give you a 10-minute break and we'll come back and start GI.